My name's Catherine. I'm a physiotherapist. I use she and her pronouns, and I'm making this video to educate people about gender affirming care in pelvic health settings. So that can be physiotherapy, occupational therapy. I really think it extends even past that into other therapy areas because a lot of times these folks are not just coming into us for specific things related to gender, but people of different genders exist and encounter different healthcare needs all throughout their life. And sometimes gender may or may not play into that. So this is more of a community focused kind of webinar type video. And I'm hoping that it's useful for those of you who might not choose this as a particular specialty area, but just wants to make sure that they're giving the best quality care to everyone walking through their door. So yeah, let's get started. So this is a presentation about gender affirming care, and yeah, feel free to leave me any questions or information in the comments. I'd love to hear from you. So our goal with this presentation is for you to be able to use gender affirming language in your practice, understand the unique impacts on health for gender diverse people, understand gender affirming chest and pelvic surgeries, including pre and post-op care, and how to make your clinic spaces more inclusive. So you can see a lot of this relates to more than just physio and occupational pelvic health, but it really is, good for a lot of different clinicians to be aware of. So just a brief little history on gender here. A lot of, discourse and discussions in the media kind of make it seem like this is a very new thing, that the internet is sparking a lot of this, but actually there's a lot of evidence dating back many years, all the way to the Mesopotamians, that they believed, the goddess Inanna could change a person's gender from male to female or female to male. They also had a term to refer to people who were between a man and a woman, and this included actually many priests in that society. A lot of people are aware that Indigenous people across Turtle Island recognized two-spirit people. The ancient Egyptians had multiple genders recorded, and there's also examples of non-binary genders in communities across Asia. So colonizers and settlers have really tried hard to erase these people, which came down to a lot of white supremacy kind of driving those policies. And despite that, these people do exist, and whether they're out in the community or haven't come out yet, it's almost certain that people are going to walk through your door, and it's much more welcoming and nicer if folks can feel like they're walking into a welcoming environment. So I'll leave this here. Feel free to take a screenshot, write some of this down. It's a lot of text, so I'm not going to go through all of it in such detail, but just some brief definitions here: transgender, non-binary, pronouns, queer, etc. Two that I will just highlight here: AFAB means someone who's assigned female at birth, and AMAB is assigned male at birth. And then there's also a few terms here that we're not going to recommend using, just going off what the community has recommended and prefers. And also just remember that not all trans people will choose to or have access to hormones or surgery. And regardless of access to medical care and their own personal decisions, every trans and non-binary person is valid. So here's some examples of inclusive terminology. So as I mentioned, I'm a pelvic health physio, and I was taught to use the term breastfeeding. But actually, if we just change that a little bit to chest feeding, all of a sudden we're inclusive of all people who are parents in that part of their life, regardless of whether they have a breast. Now, people can get pregnant who are trans men or non-binary and have had top surgery, so they don't have breasts. People might have mastectomies for medical reasons. There could be parents who aren't born with breasts, who have become parents through IVF, surrogates, and are feeding off their chest using devices that help them do that. So there's a lot more variety in how that part of parenting and early parenting looks, and chest feeding just includes everybody. So I really like to use that. Instead of specifying their particular anatomy when it comes to genitals, we can just say genitals. You can call people and humans instead of men and women. This is particularly important when you don't know someone very well. If you haven't asked their pronouns, it's good to not assume, especially if you're referring to them with your colleagues in front of them. It's pretty easy for people to get misgendered that way. If you call your practice anything related to women's health, I recommend changing that to pelvic health. We can call people parents and caregivers instead of mom and dad. Using birthing person instead of mother, partner and spouse is a good way to refer to people. And keeping in mind, polyamorous people and families exist as well. So sometimes there are multiple partners, multiple spouses, and family dynamics that might not look familiar to you. But it's good to just leave space there so that if someone is in a position where there's multiple partners, that doesn't become some kind of awkward moment where you have to redo the paperwork or, change things on that end. So some more language tips here. The biggest one is ask what they prefer. It's never a bad idea to ask. You can't really go wrong there, and it opens the door. It makes people feel a lot more relaxed when they can just set those, guidelines for you right out of the chute, and just make everything really clear. I've certainly had that in my own practice where I asked people, and in one situation I asked an older gentleman who was really happy and excited because no one's ever asked them that before, and sometimes I know people are kind of pinpointing who they ask pronouns with when they come in the door, but really we should just be asking everybody. You don't know someone's story. There are lots of trans, non-binary, and queer elders that often get left out when asking pronouns if people ask them at all. So just making that kind of a habit to get into. If you don't feel comfortable asking, always try to introduce yourself with your pronouns. So that just opens the door that you feel like that's a normal part of introducing yourself. So then if they want to do the same, that's kind of a welcome thing for them to do. So I always say my pronouns as soon as I meet someone. Remember, we're all going to make mistakes. People see the effort that you're making, and I think the fact that you're trying is really amazing, and honestly more than most people are doing these days. So don't give up. If you get awkward moments, just know we all go through them, but just correct it, move on, and the more you practice, the more natural it becomes. every human has a pelvic floor. So especially for those people like myself who were kind of going through school and being trained when it was always called women's health. Actually, every human has a pelvis, so that extends to cisgender men, trans people, non-binary people. Kids have pelvic floors, elderly people have pelvic floors, literally everybody. So there's a whole kind of scope here of caring for our pelvis and our pelvic floor that should include everybody. And then I just have this slide in here as a little reminder. Sometimes, and there's like multiple situations outside of gender that this happens to, but we might have, someone come into our clinic who's like, they're trans, and we start asking about bottom surgery or hormones, etc. But that might not have anything to do with why they come in. So don't focus too much on the gender side of things if that's not why they're there. Trans and non-binary people are going to come to you because they sprained their ankles or because they had a work injury, or, there's many different reasons why people might seek healthcare, and it doesn't always have to do with that one part of their identity. I've had patients as well who use wheelchairs that every single time they go to a doctor or physio or something, people assume that that's why they're coming in, and they're actually just looking for something completely unrelated. So just keep that in mind as you're going through your practice too. So here are some non-surgical gender-affirming practices, and I like to highlight these because a lot of times people assume if you're in gender-affirming care, you're just working with folks who are going through surgery, and that's not all of it. There's a small percentage of people who will actually go through surgery because of medical gaslighting and difficulty accessing care, financial reasons, and people just don't want to do it, which is totally valid. And you can still be a trans person and not get surgery. So this is some examples of non-surgical gender-affirming practices. So pelvic physiotherapy considerations when you're taking testosterone. So if this person has a vulva, they're going to notice some increased vaginal dryness. They'll notice increased clitoral size, which is also known as bottom growth, and increased libido. Some other changes that happen when someone starts taking testosterone is the development of facial hair, deepening of the voice, increased muscle mass, so they build it more easily, increased energy. They may have hair loss, especially as they get older. Most people don't have their periods anymore. They may get acne for a while, and there's also some changes in bone mineral density for some people. So especially in the physio setting, it's important to monitor that, especially if they end up, with a fracture or noticing some kind of pattern there. So some of this relates to physio, some of it doesn't, but it's just good to be aware of, and some of those extra little things that might happen when they're on T. One of the things I've seen a lot of, and that there is like a growing body of research around, is pelvic pain and testosterone. So a lot of non-binary people and trans people taking testosterone are going to notice pelvic pain. And this is evident, especially when they're having sex and being intimate with other people. Sometimes that can trigger it. And a lot of these studies kind of blame this on taking testosterone because the two kind of coincide together there. However, I just like to highlight the fact that there's a few factors that haven't been taken into account during these studies, such as like the medical gaslighting that they might be encountering the inability to access healthcare, avoiding healthcare due to trauma and other factors. Just to share a story on this too, I mentioned how, if you're taking testosterone, most people stop having their period, but I've had people who are on taking T, stop having their period, but every now and then might have a little bit of spotting and extreme endometriosis symptoms that completely get overlooked just because they're taking testosterone. So if you're seeing these folks in your clinic, you're going to have to be a really big advocate for them. There's a high chance that they've had some trauma with the medical system, and unfortunately, it's difficult to get these people the tests that they need. And when they do get the tests, it can be extremely uncomfortable in these clinics that are kind of, pink and targeted around women's health. So we really need to be there for these folks and make this kind of part of healthcare more inclusive. So keep that in mind when you're seeing them. Try not to be another person who just blames it on testosterone. Testosterone is hugely beneficial for their mental health. So, coming off of it is really going to be a last resort. And some people can have periods when they're on it. So, keep in mind things that might play into that. They can get endometriosis, they can get cervical cancer, PCOS, vaginismus, and they can give birth, they can go through menopause. So we just have to remember all of this. These are a few of the studies I was mentioning that looks at pelvic pain and taking testosterone in trans masc individuals. So pelvic physiotherapy, I realize I missed the P in physiotherapy there. When someone's taking estrogen, so you're going to notice a decrease in size of their phallus and testicles, and they're likely to experience erectile dysfunction. Now, this isn't necessarily a reason to not take it. As I mentioned with testosterone, some of these hormones can be hugely beneficial to mental health. So we really want to support this as much as we can. And some people can be intimate without the use of their phallus. So there's lots of different ways that intimacy can look for folks. And we shouldn't be kind of putting the heterosexual norms on our patients here if estrogen is going to be a really important thing for them. Obviously, we want to educate on the side effects, but keeping in mind that might not even be anything for them to worry about. Other changes that can happen are decreased muscle mass. You're going to have a change in fat distribution with both estrogen and testosterone. So for estrogen, we're going to see, more fatty tissue around the chest area. There is an increased risk of blood clots. It might notice some reduced male pattern baldness, and reduced male pattern hair growth. So we'll see less hair on the face, chest, abdomen, that kind of thing. And this is for some people, but not every person. So keep that in mind. And also possible changes in bone mineral density. Again, usually it comes from the anti-androgen therapy more than the estrogen, but many folks take that together. And just like I reminded everybody in the testosterone part there, trans women can get testicular cancer and prostate cancer. Not just trans women either. We can have intersex people, non-binary people. All of the genders can get these. So binding is a practice that many people who are AFAB use to get the appearance of what's seen as a more masculine chest. And it's a garment that just wraps around the chest and holds that tissue closer to their kind of rib cage. So it just makes you look a bit more flat around the chest. Sometimes this helps with gender dysphoria, and it just makes them feel more comfortable. So a lot of people use this. It's a great option, if they're not able to get surgery, if they don't want surgery. There's lots of different reasons there. And sometimes people use like tape, bandages, and other methods to hold it down. This is less ideal for skin integrity, so we really want to advocate for using proper garments for this and not kind of DIY at-home binding. The recommendation for people is to not bind more than 8 hours a day, and even at that, people can develop complications. So a study of many participants, over 1,000, found that almost 90% of them had experienced at least one binding related symptom. And most of those people believed that it was important to discuss chest binding with their healthcare provider, but only 14.8% had actually sought care. So that's a huge discrepancy that people are not getting help for, who really need it. So binding can cause many complications, and it's our job to help people come up with solutions and strategies that keep their mental health taken care of, and take care of the gender dysphoria, but also take care of their ribs and their breathing and their health and their pelvic health. So possible binding complications that I've seen in my practice are pain around the ribs, the chest, shoulders, neck, pelvis, back, etc. And I've seen people who have diaphragm and pelvic floor dysfunction. Now, if you imagine you're not moving the ribs as much, you're not going to get as much diaphragm expansion on the inhale. So that means your pelvic floor is not going to lengthen as much as it would otherwise, and this can create quite a different pressure dynamic in the abdomen. We can also notice some bruising and skin changes, some digestive problems, deconditioning, or general stiffness around the ribs and mid-back. But we need to remember, again, this is a huge thing for people's mental health benefits, and we need to kind of make a plan that works for the person. So a lot of times I'll say, if they have to work, say they work at a hospital and have to do a 12-hour shift, obviously that's longer than the 8 hours that they're supposed to wear their binders. So we might make a plan to get a binder that's one size up, so it's not quite as tight, but still gives that bit of compression, and that we have a really good mobility routine for ribs, breathing, shoulders, pelvis, all of that before and after their shift, so that they can get that movement and get a routine that works for them. So it's about just working with these folks and seeing what works, what doesn't. People can wear baggy shirts and sports bras, and we can come up with things that might help that way. So physio assessment, basically we always want to ask for consent. That's always going to be a big part. Like I said at the start, ask what language they prefer. You do this for their pronouns. Ask about their anatomy, if they'd like to use gender neutral language, if they have pronouns they want you to use for them. It's going to be different from person to person, but it's always better to ask. Do your usual subjective, identify what's wrong, what their goals are, take a medical history, take any symptoms, assess their breathing mechanics, thoracic, shoulder, neck, and low back mobility. A pelvic floor assessment, if necessary. Always give the option for non-internal exams. This is a huge one. I almost always recommend doing non-internal exams unless there's a really important reason that you need to feel something like that. Most of these people have a lot of dysphoria, a lot of distress around this part of their body. Even talking about it can increase the stress response, the fight or flight, increase tone in the pelvic floor. So I don't think you're going to get a hugely accurate result through an internal exam if someone has gender dysphoria anyways. I think what I've done in my practice is use the language they want, have them sit on like a rolled towel or something where they can kind of feel the pelvic floor themselves, and do some kind of mindful work, see what they're noticing, teach them how to lengthen it, teach them how to contract it, and try to get them doing that with some space between you two rather than having you feeling that necessarily. And that can be much, much easier, and they can be much more receptive to that because it's not actively kind of triggering that dysphoria. So I recommend considering that for your pelvic health practice. And also check skin, so around the binding, especially if you're worried about any bruising or that kind of thing. Physio treatment for binding, it's always going to be a bit about treating what you find. Everyone's going to be different. Always ask for ongoing consent. Gender dysphoria can be really distressing, and people in this population are at a higher risk of physical, sexual, and mental trauma. So what might seem like a simple rib mobility technique to you as a physio or OT can be really triggering for someone else. So just provide them with a few options, and remember there's a lot of value in hands-off treatment. You can do a lot of breathing and stretching and mobility work just on the mat, on the floor. So keep that in mind, and just remembering that dysphoria piece for everything that you're kind of doing. So some physio tips if they're having a hard time limiting binding to less than 8 hours per day. Try wearing a sports bra and loose-fitted clothing instead of a binder, as I mentioned. Daily routine of deep breathing, daily stretching, and like I said, if their work shifts are longer than 8 hours, consider buying a binder one size up. Working with them to see what's the best solution. So there's some other non-surgical gender-affirming practices. Some of this will have an impact on health. Some won't have a huge impact, at least on physical health. Tucking, for one, is something that we might have to help them with. So tucking is using tape to hold the phallus against the perineum towards the anus. And some people will manually push the testicles through the inguinal canal as well. There are undergarments will help make this practice more comfortable, but some people do use tape. So it's important that we make sure that they're using tape if they're doing that the correct way, making sure that they're not pulling or pushing it too aggressively, and just knowing that sometimes this can impact fertility and cause erectile dysfunction, which, as I mentioned before, might not influence people's lives at all, but it's just good that they're aware of that. And if this practice is making their pelvic floor tension increase, or if they're having any kind of muscle imbalances while doing this, that might be something that we have to help with. Packing is unlikely to influence us a ton, but we're going to, in that practice, use a prosthetic phallus and scrotum to place in their underwear, so they get the appearance of having what is typically seen as a masculine pelvic area. Haircuts can be gender-affirming care, changing their name or pronouns, and wearing different clothing and finding new ways to express themselves, just like nail polish, jewelry, etc. So gender-affirming surgeries is usually what everyone thinks of when they hear kind of gender-affirming pelvic health care. As I mentioned, it's a lot more than this, but this is certainly a population who can use our help both before and after. So, some preoperative care for gender affirming surgery. One thing that I haven't heard tons of people talk about, but there's some interesting research coming out, is imagery. So, really trying to imagine your new anatomy. What does it look like? What does it feel like? How does it feel to use it? Thinking about having that in different circumstances, whether you're walking through the mall or being intimate with a partner. This can have a pretty, interesting impact on the sensation after surgery. And there's been some cool studies coming out recently that have shown promising results about, the sensation return after surgery for people who do this. Pelvic floor muscle training, specifically focusing on lengthening and relaxing the pelvic floor with deep breathing. This is so important before surgery because our muscles, especially if you're getting pelvic surgery, but even chest surgery, they're going to be very tight afterwards. So this really helps them kind of relax, lengthen, really get that mobility there pre-op, and it's going to make it easier to do that activation post-op because you're so familiar with how it feels. Diaphragmatic breathing, it kind of helps with that mobility side of things in the pelvic floor. And it's also an important exercise post-op, so if you're practicing it beforehand, it's just going to make that even easier. So we will also want to teach people proper posture for bowel movements, encourage squatty potties, I love those, or whatever kind of stool or setup you can get them having at home. Hip, thorax, other mobility exercises are good. Advise on any preparations, so getting a donut pillow to make sitting easier, moving things around in their home for after top surgery so they don't have to reach overhead. They might have their favorite cups on the top shelf, and we just get them moving a few of them to the top of the microwave so they can reach them. Address any present concerns from the patient on function, pain, and goals. So perhaps they're going into bottom surgery, but they've also had a hip injury 2 years ago that's kind of niggly. Like, you can address things like that at the same time that will help. Chest construction and breast augmentation surgery is also known as top surgery. So removing the breast tissue and either reducing the size of the breasts or constructing a chest that is typically seen as more masculine is what we call chest construction. How does this impact pelvic health? A lot of people ask. It's the altered breathing mechanics post-op has an impact on the pelvic floor, possible changes in your posture after the operation, and lots of emotions and impact to the nervous system leading to pelvic floor changes. So the most likely situation after this is going to be a tight pelvic floor because there's not much movement of the diaphragm and stress levels might be high, even though it's a really exciting thing. It's a big surgery and there's going to be lots of emotions that come along with that, both good and bad. So having space for that and just knowing that these folks probably would benefit from some pelvic floor work. We're always going to ask for consent, ask what language they prefer, and then doing the usual subjective and objective assessment pieces, really focusing on breathing, mobility around the upper back, shoulder, neck, low back, pelvic floor assessment. And I always recommend non-internal unless absolutely necessary. Checking their skin, you can check their scar, just making sure everything's healing well. And for this surgery, it does depend on the surgeon, but I think for most people, they want to keep the shoulder movement below 90 degrees, sometimes up to 6 months. And this just helps with the scar healing. It's going to make the scar a lot thinner, because you're not stretching that tissue so much as it's healing, and that can be more appealing for a lot of people to have later on. Physio treatment, so always treating what you find. It's going to be different person to person. Keeping in mind the gender dysphoria piece, even if they did just have surgery, and the trauma-informed care piece as well. You're probably going to do some breathing exercises, thoracic mobility, pelvic floor muscle therapy, lots of advice and education, pain management. You're going to work on upper limb function below 90 degrees for the first 6 months. And as I mentioned, this helps with scarring. We're going to do some scar massage when able to. And then after 6 months, we can mobilize and strengthen past that 90 degrees of shoulder elevation. At this point, they're going to be very stiff. So it's going to be, quite a process to get that range of movement back. And these people would really benefit from having someone guide them through that process. Breast augmentation is surgically increasing the size of the chest using implants. There's less scarring in this surgery than chest construction, so people are usually able to work on range of movement as tolerated afterwards. You might get similar kind of impacts to the pelvic floor with altered breathing mechanics, possible pelvic floor muscle tightness, and the physio assessment and treatment is going to be quite similar, but you're going to not have as much of an impact on the shoulder because you can move that a lot more easily after the surgery. Always ask for ongoing consent and, keep working on that upper limb function and mobility after this surgery. Phalloplasty and metoidioplasty is also known as bottom surgery. So this is the surgery that constructs phallus for people who are looking for that. So the difference is metoidioplasty is a little bit less involved, and the surgeon is going to use the lengthened clitoris that has been, growing since they start at T, and kind of using the tissue around that area that's already there. So you don't have secondary or third surgery site. You're just going to use, kind of what's already around the genitalia. People can get urethral lengthening during the surgery, which just means they'll be able to stand up to pee afterwards. And there's also the option of removing internal genitalia. So that's not necessary with this surgery, but some people opt for that, whether at the same time or in a separate surgery. Some people also choose to have a scrotum created from external genitalia, like the vulva, and they also have the option of testicular implants at a later surgery. But the phallus itself in this one is going to be smaller. So it's kind of smaller than what we would average, a size for a person who's AMAB with a phallus. You can't have penetrative sex with this surgery. You can't, be the one penetrating, but they can still orgasm after through stimulation of the phallus, and these people can still have orgasms just through other means. Phalloplasty is a different type of bottom surgery where the phallus is created with the intention of being able to penetrate during sex. There are usually multiple surgeries involved in this process, and the person needs to have their internal genitalia and organs removed. So the ovaries are optional, but they need to have their uterus and cervix removed at least 6 months prior. The phalloplasty includes urethral lengthening. Sometimes they do this or finish this part at a later surgery. A full thickness skin graft is taken from another part of the body to form the skin around the shaft. So typically people use the forearm. And this is because the sensation there is better. There are people who decide to use skin from their thigh or back, and they just don't find they have the same level of sensation return afterwards. And then there'll be a partial skin graft taken from somewhere else, like the thigh, to cover up the original full thickness skin graft. So there will be a lot of scarring, as you can imagine, after the surgery. And some folks will choose to have a scrotum created from external genitalia, and they also have the option of testicular implants later. A lot of people who do go for phalloplasty also have an erectile device implanted at a later surgery. And this is where you'll have a saline kind of reserve internally placed above the phallus, and it's kind of like a little tube that goes down the shaft of the phallus that can fill up with saline when they want to have penetrative sex. And one of the testicles kind of acts as a pump to move the saline into the phallus. So you can do that and have basically an erection, and then they can kind of move that saline back to the reserve afterwards. So full recovery from this can take a year or two, maybe even a bit longer with phalloplasty. So it's important that patients are aware of this, and that there are people like yourself to support them along the way. So stage 1 after phalloplasty and metoidioplasty, just remember that the body's gone through a major operation, and they're going to need time to rest. A lot of this information, it comes off the free gender affirming surgery guides I have on my website, so that's why it kind of reads as I'm talking to the person going for surgery. So you want to follow post-op orders about how often to clean the neophallus, and the directions on when to take medication and any other advice they gave you. Follow directions on caring for the catheter. That can be in place for a few weeks after surgery. They're going to want to avoid heavy lifting, and keep taking deep belly breaths. Look at your new anatomy, touch your new anatomy, and rest. So looking and touching, keeping that imagery going, all of that can really help with the sensation after surgery. Just like we did before with bowel movements, use a stool or a squatty potty, avoid straining, and try and focus on deep inhales while having the bowel movement. People will often be on stool softeners after surgery, but chia seed pudding, prune juice, staying hydrated, all of those good bowel habits can help. Exercise-wise, in the first stage here, it's going to be quite small, so people can walk, small distances if it's tolerable, but definitely not trying to overdo it. Easy activities to keep people busy at home is going to be the best. Reaching out to people on the phone, social media, getting some connection. Meditation can be a great activity during this time that also helps that nervous system calm down. Swelling, we want to make sure that we apply ice to the surgery site, with a barrier, of course, for about 20 minutes every hour or so through the day. So, like I was mentioning earlier, why do we want to touch your new anatomy? A lot of the early evidence around metoidioplasty and phalloplasty is looking at kind of urology and the function of the penile pump, but less so about the sensory component. There's a team in Portland that have come up with a post-op protocol that focuses on getting sensation optimized, and they're setting the stage for future investigations, but just released this protocol last year. So basically trying to do that visualization I was talking about, some tactile or touching sensation, and progressing that as they go through their recovery. For phalloplasty, we want to make sure we're considering the secondary surgical sites. So there's probably going to be a full thickness forearm graft and a partial thickness one somewhere on the body, and these areas will need care and attention, and they're going to need scar care afterwards. So it's almost like following advice from like wound care, or I got this exercise plan from a burn unit, actually, because they often do full thickness grafts as well. And this is actually, no, I misspoke. These are the exercises from GRS in Montreal. I had another little booklet here that I was showing people for forearm exercises from a wound care perspective. But keeping all that advice in mind from the place that you get the surgery. And this is an example of one spot that they do the surgery in Canada. And they just have some little exercises here to keep mobility in the forearm and the leg after that skin graft. So you want to make sure you wash your hands often as well, just to prevent infection. Stage 2, so 3 to 8 weeks post-op. Once you're starting to feel a bit more energized, people can start doing very gentle movements, such as easy stretches, again, kind of breathing, maybe some restorative yoga type work, practicing pelvic floor lengthening, that kind of thing. Once the scar has closed, you can start massaging the area to prevent adhesions, and going for a little bit of a longer walk, not tons, but gradually work up to walking for an hour a day, and just slowly starting to handle more tasks around the home. So you want to keep lifting to a minimum, and when you have to lift, make sure that they're exhaling at the same time that they're lifting, and this is going to prevent too much pressure onto the pelvic area. Stage 3 is about 8 to 12 weeks plus. So this is where I find a lot of people can get a bit frustrated, because it's kind of the time that everyone's like, oh, you can go back to work. But a lot of people still feel very not themselves. And it's important to remember that the body's gone through a lot, and it can take a lot longer before people feel comfortable lifting heavy things or doing usual tasks. There's also a whole wide range of emotions here, and all of them are valid. Make sure that you're encouraging them to reach out to local trans support organizations or social networks, just so they feel really connected and taken care of in this vulnerable time. Encourage them to take it one step at a time, get back into things gradually. They should be able to self-manipulate the phallus for pleasure after 6 weeks. However, it's recommended to wait until 8 weeks before anal or oral sex. After the erectile device implantation surgery, people can usually resume sexual activity around 4 to 6 weeks, but it's important to listen to the advice from your particular surgeon. It's also normal to spray everywhere when they pee after phalloplasty or metoidioplasty with the urethral lengthening. This should improve as swelling decreases, but it shouldn't last more than 6 months. If it does, reach out to the doctor. I usually say people should try and still sit down to pee until the swelling subsides, and then they can, transition towards standing. So once the graft sites have fully healed, they want you to start wearing a compression sleeve to promote healing, and gradually doing more normal activities with the hand, wrist, and elbow. This is, of course, for people who have the full thickness graft on the forearm. They want to progress to stretching, scar massage, and very gradually increasing the weight that you can take through that arm. A physiotherapist can obviously guide the individual through this, at that individual level, and just make sure that they're getting back to their activities well, and remembering that the sensation in the phallus as well as the secondary graft sites will take time. The ability to reach orgasm will differ between people. It's good to practice touching the area, once scars have healed, with different textures. Use vibration and continue that imagery type exercises that they start at pre-op. So vulvoplasty and vaginoplasty are also known as bottom surgery. So this is for people who were born with a phallus but want to change that to what's typically seen as a more feminine pelvic area. So zero depth vaginoplasty or vulvoplasty is one of the options for people who want the appearance of a vulva but no cavity for penetration. So there'll be a urethral opening for peeing. The person will have a clitoris, and most people who undergo this procedure can orgasm through the clitoral stimulation. Vaginoplasty is a bit more involved, and it's for people who both want the appearance of a vulva and a vagina that's capable of receiving penetration. So after the surgery, there won't be a penis or testicles, and the person will instead have a vulva and a vagina. The person will have a clitoris, and most people who undergo this procedure can orgasm. The people who have a vaginoplasty can obviously orgasm through the clitoris that they construct. Some people can still orgasm through penetrative sex, however, because you have the prostate still there, and depending on the person's anatomy, they might be able to stimulate that through penetrative sex. So it's not uncommon for people to be able to do both. The recovery for a vulvoplasty is easier than the creation of a neovagina in full depth surgery, and it tends to have less complications. That being said, it's still a major surgery, and people will take time to recover. So at least 8, probably 12 weeks before people are getting back to work and usual activities, and it's going to be a lot longer for the swelling to go down, like 18 to 24 months sometimes. Vaginoplasty is obviously a major surgery, and you're going to need time to recover from that as well. It's usually about 12 weeks until people are returning to normal life activities, but again, much longer before they feel kind of recovered. Dilating is a really big part of vaginoplasty. So when they do the neovagina, they're going to need to keep putting something of that shape and size in for the rest of their lives in order to keep that cavity there. If they don't, they're likely to get what's called vaginal stenosis, where the cavity becomes quite small, so it might shrink in depth and width, and they may not be able to handle penetrative sex, and it sometimes can cause pain in itself. So dilating can be scary and painful right after surgery. It's really important that they keep doing this, even if there's some minimal bleeding and, it says wound dissonance, but wound dissonance. Pelvic health physios are excellent resources to help people navigate this and to help people keep it up. A lot of times it's hard. You've gone through a major surgery. There's lots of emotions, and especially right off the bat, the dilating schedule doesn't leave much time for anything else during the day. So it's tough for people to keep up with this, and it helps to have healthcare team members that are actively working on it with them and supporting them. So we want to, especially from the pelvic health side of things, teach them how deep breathing can help relax the pelvic floor and encourage them to downregulate the nervous system in preparation for dilating. So this might look like, singing their favorite Taylor Swift song, or just doing things that stimulate the vagus nerve. So sometimes doing a little bit of ice massage around the jaw helps with that, humming, singing, doing some deep breathing. You can look up strategies that might work for the particular person, but anything to help with that in preparation for dilating will be great. Help them find a good lubricant. This also is really important. Practice pelvic floor lengthening outside of dilating time, and even better if you've done that pre-op. Working on hip mobility and stretching as much as they can post-op. Obviously, there's scarring there, so they might not be as mobile, but even just some gentle little hip rocking and kind of easy movements like that can help. So my screenshots of these aren't brilliant, but there's 4 sizes there of dilators, and size 1 is the smallest, despite what it looks like here. And so we want to start with size 1 with the goal of getting them to do size 4 as quickly as they're able to progress. So this is the guidelines from GRS in Montreal, and you want to make sure you're washing your hands, the dilators are clean, making sure that you're putting an underpad on the bed just because there is likely to be bleeding, and relax and take some deep breaths before doing this. Now you want to hold the dilator by the base pointing upwards, and you apply approximately a tablespoon or so of lubricant. So you use a mirror during this to insert the dilator. You do about 5 centimeters at a 45-degree angle, and then lower the angle so it's parallel to the bed, and you continue to insert. When the bottom of the cavity is reached, you're going to exert a constant gentle pressure. You don't want to apply too much pressure, but just a gentle bit of pressure there. So you keep the dilator in place, and you gently remove it, place it on the underpad, and you clean the remaining lubricant off your genitals. You always follow that with douching as well. So stage 1, and I miss kind of how people do the surgery here initially there, but just so you're aware, the vulvoplasty is where they make the clitoris using kind of the tip of the penis, and they bury it just at the site of the clitoris there at the top of the neovagina, and then use the testicle skin to make the vulva around that. For the full depth procedure, they do an inversion technique where they keep that penis sensory part just at the clitoris there, but the rest of the skin they kind of fold into the pelvic cavity there, and they kind of fasten it there during the operation to create that cavity, and they'll stuff it with gauze for the first I think it's like day or few days, and then they'll get you that out and get you on a dilating schedule before leaving the hospital. So just so you kind of have an understanding of how that all happens. They are doing, some people are doing vulvo or vaginoplasties using the internal abdominal wall tissue. I think it's less common, but perhaps getting a bit more attention lately. So obviously keep an eye out to see if surgical techniques change as you're working with these people. So stage 1, your body's gone through a major operation. It's going to take some time. So you follow their post-op directions about how to clean the neovagina or vulva and any other directions, including when to start taking medication again. Follow directions on dilating if you've had a vaginoplasty. Remember to lengthen the pelvic floor and inhale as you insert your dilator. Avoid heavy lifting. You want to keep taking deep belly breaths, and just as I said previously, look at the new anatomy, touch the new anatomy gently, of course, and rest. So with people who go through this surgery, if they're on estrogen, there's going to be recommendations that they come off of it a certain amount of time before surgery and stay off of it afterwards. And that's just because of the blood clotting risk. But once that's kind of healing and things are going well, they can take estrogen again. Bowel movements, same kind of advice we gave during the phalloplasty there. Same kind of thing with the exercise, walking, but not overdoing it, finding easy activities that you can do at home, meditation, breathing, that kind of thing. And ice as well, about 20 minutes every hour through the day can help with swelling. This is the stage 1 to 2 dilations program. So just so you can see how intensive it is, they give you the option of which dilator to use. And how long. So option 1 is using number 3 for 5 minutes and then number 4 for 20 to 25 minutes. Otherwise, you can kind of make that a bit of the smaller one and doing that for the same amount of time. And then you're going to shower afterwards, and then you're going to douche afterwards. And you do that first thing in the morning, you do that at noon, you do that in the afternoon, and you do that in the evening. 2 of those times you want to do a sitz bath afterwards. And that's just where you kind of have a tub or a container that you can sit just your pelvis into and not the rest of your body. So that way it keeps things a bit more clean, so you're not kind of putting your feet and other things in there with the scar that's healing. So it's really intensive. I mean, by the time you finish all of that, it's you get an hour, and then you have to get ready for the next round. Stage 2, 2 to 12 weeks. So, gently start doing a bit more around the house, start doing a bit more walking, that kind of thing. And you transition from 4 dilations a day to 3. And at month 2, you can start beginning scar massage and exploring the clitoris area with your fingers. Make sure you always have clean, washed hands as well. Around month 3, we're still at 3 per day, but you're making sure that you're trying to work up to that number 4 dilator for the 20 to 25 minutes. And then, people may or may not feel like they're getting back to normal, but and that's okay. Most people will return to work around 12 weeks, but it depends what their job is too. People are going to feel a wide range of emotions. All of them are valid. Making sure they have good supports around them, whether that's family, chosen family, or trans support organizations, that kind of thing, and just encouraging them to reach out. Take everything one step at a time. A lot of folks get really frustrated at how long it takes to recover, and I think it's good just to have that expectation going into this. Give yourself lots of grace. If people participate in sports, gym, or other exercise, always go back slowly. Start with extra light weights, slow jogs, and just slowly work your way back over the course of a few months. People are safe to engage in intimacy after 3 months, although people might want to wait longer, and that's okay. Prior to this, they can use a vibrator for stimulation if it feels good, but no oral or anal penetration. No penetration into the neovagina before 3 months either. And just like the other surgeries, it's pretty normal to spray everywhere afterwards when you go pee. This is just due to the swelling. So if it's persisting much longer than 6 months, reach out to the doctor. Hopefully it's okay by then, but also I know with these surgeries, swelling can last a lot longer than people think. So, it might just be a case of waiting a bit longer too. So here are some dilation schedules for 4 to 6 months, where you drop down to 2 times a day, and then after 7 months where it's just once a day. And then after a year, you're going to dilate once a week. Some people want to do this more often, which is totally fine. I would always err on the side of caution. And other people, if they're engaging regularly in penetrative sex, might have to do less. I would say what I recommend, because every penis and strap-on size kind of varies, you're probably better off doing the dilation every week, even if you're engaging in regular penetrative sex. But you have to kind of talk to the person and figure out what works best for them. So up to 29% of people post-vaginoplasty will develop symptoms of sexual dysfunction, but physio has been proven to be a very valid conservative method of treating this. And another study found that 42% of people who had pelvic floor dysfunction initially before the operation, and the people who did post or pre-op physio dropped to about 28% about 6 months after the operation. So that's a huge drop just by looking at people who did pre-op physio. And the people who just waited until post-op to start physio had much higher rates. So it's important that we, find a way to welcome these people and make this more accessible to folks before their operations, because it has a hugely beneficial impact afterwards. So there are complications that can come along with surgery, as with anyone. If there's excess bleeding, severe pain, signs of infection, inability to empty bowels, this is all reasons to see emergency room. I have A&E there because I gave this presentation in the UK, but I'm working in Canada right now, so we'll say the ER. Vaginoplasty complications include granulation tissue, which just needs some treatment with silver nitrate. Wound dissonance is quite normal, but watch for excess bleeding, and bowel perforation. So that's obviously an emergency situation. And sometimes that can happen when they're making the cavity. If there's any kind of impact or sutures or something that hits the bowel, that is a low risk, but certainly a possibility. So definitely something to just be aware of. Pelvic floor dysfunction is super common. So longer term at risk of vaginal stenosis if they're not dilating. So making sure that we treat that pelvic floor dysfunction so that dilating becomes easier. If they're unable to urinate, again, send to emergency. And chest construction patients are at risk of excess scarring if they do a lot of overhead heavy lifting in the first few months. This is really hard for people who like going to the gym. So just especially if you're kind of the physio with them, give them lots of exercise ideas that they can keep their arms out of elevation and still building strength. So you can still do a lot with biceps, triceps, forearm exercises, even some shoulder work below that 90-degree mark, just so they can still feel like they're getting back to their activities. So a lot of people already have the skills needed to treat this. You can see in a lot of the treatment ideas there, it's all things that most physios and OTs who work in pelvic health are kind of aware of, but it's just taking that extra time to acknowledge the extra things that might impact someone who's going through this, who also deals with gender dysphoria or has medical trauma or experiences a lot of gaslighting, young folks who are kicked out of their home, so their social situations might not help with recovery from these type of surgeries or complications that might arise. So we really want to have that kind of extra knowledge in the back of our minds, but as far as the actual therapy, I'm pretty confident that anyone watching this has those skills if you were trained in this area. And also, gender diversity is not new, it's valid. People of all genders exist all over the world, and we just want to live peacefully, be respected, have equal access to healthcare, education, and other community resources. Language is evolving. We're bound to slip up at times. It's not a reason to give up or try and ignore this community, because the queer community in general needs allies and champions who are trying to make the world a more equal place. And because there is so much inequality, there's a huge lack of trans people and queer people. Even, intersectionally, there's a lack of BIPOC and disabled people in these healthcare spaces in our position. So we really need to champion that and be allies and make the healthcare settings a better place than they are right now. There's a lot of online resources to help guide you if you're, looking for other physios or practitioners who do this, online resources to help guide you through the post-op recovery. The GRS Montreal has tons of really great information on there that I look at myself and send patients to. So I think that's definitely a great resource. You can have a look at any of the articles that I posted in this presentation. And just, keeping in mind that trying and slipping up every now and then is normal, and just the effort is really, really appreciated. So thank you. I did this presentation, as I mentioned, in the UK. So there's a little organization there that I was supporting at the time. I would encourage you to go research who your local trans or queer support organizations are. Touch base with them, learn from them, follow queer and trans and non-binary people on social media. They have some great content, and I always think it's best to listen to the community, and especially when it comes to language, go off of what the community is recommending, and that's always going to be a really big help. See what people are sharing on their social media pages is sometimes more information than we get in our subjective exams in clinic. So thank you.